welcome to Project ADHUNA. Myself, Dr. Sujata Dalvi, Dr. Ritu Khanna and Dr. Jayshree Patnaik will be talking on the topic of anemia in pregnancy and role of IV iron, especially FCM, so far as anemia is concerned. Anemia in pregnancy is a significant public health concern impacting both maternal as well as fetal well-being. IV FCM, that is ferric carboxymaltose, has emerged as an effective treatment option. This presentation will explore the latest evidence, clinical guidelines and practical insights on the safe and effective use of IV FCM to optimize maternal health outcome. This presents a classification of anemia based on the hemoglobin levels. While we often focus on severe anemia, close attention should be given also to moderate and even the milder form of an anemia. This is because untreated cases of either moderate or a mild can progress to severe form due to ongoing hemodilution, increased iron demand and even non-compliance to an oral iron. As you can see from this table, the causes of anemia in pregnancy are multifactorial, ranging from nutritional deficiencies to hemolytic disorders and chronic conditions. However, it needs to be emphasized that iron deficiency anemia is by far the most common and easily manageable cause of an anemia during pregnancy. Anemia is a well-established contributor to maternal morbidity and mortality, and pregnant women with anemia have an increased risk of complications including postpartum hemorrhage, preterm birth, premature rupture of membranes and infection, which significantly elevates their risk of mortality and of course morbidity. Mild anemia during pregnancy can progress to severe anemia if it is left untreated, especially in presence of an obstetric complications like postpartum hemorrhage. Studies have emphasized that even a seemingly moderate anemia, that is hemoglobin levels between 7 to 9.9 at the time of delivery, can rapidly deteriorate because of acute blood loss leading to life-threatening hypoxia, hemodynamic instability and multi-organ failure. Literature also suggests that anemia often acts as a compounding risk factor for mortality due to postpartum hemorrhage because of an inadequate physiological reserves. Moreover, anemia has been linked to poor uterine contractibility, increasing the risk of an atonic PPH, which accounts for a significant proportion of maternal deaths. Given these risks, early screening and iron supplementation and timely intervention for anemia in pregnancy are critical in reducing maternal mortality. To start early and proper treatment, it is important to ensure whether it is iron deficiency anemia or no. Iron deficiency anemia is characterized by low MCV, that is mean corpuscular volume, low MCH, that is mean corpuscular hemoglobin. Up to about 40% of pregnant women with a true iron deficiency anemia will still have a normocytic index. A combination of low MCV accompanied by elevated RDW, that is red cell distribution width, can be used as a sufficient evidence to start iron therapy. Peripheral blood smear showing hypochromia and microcytosis indicates iron deficiency anemia, whereas RDW is decreased in a case of thalassemia, and that's how you differentiate between thalassemia and iron deficiency anemia. Serum iron and total iron binding capacity are unreliable markers, as serum iron shows diurnal variation and is affected by dietary influences. Pregnancy itself can decrease the total iron binding capacity even in absence of an iron deficiency anemia. For serum ferritin levels, 30 micrograms per DL cutoff can be considered to diagnose and treat iron deficiency anemia in pregnancy. In next two slides, we will discuss about treatment of iron deficiency anemia, where it's a stepwise approach starting with medical nutrition therapy such as adding iron-rich diet food in the pregnancy, which is recommended to manage iron deficiency anemia. These measures often fall short, especially in pregnant women, and therefore supplementary iron is necessary. Now I would request Dr. Ritu Khanna to take over from here, and she will talk in details about IV iron. Thank you.
Moving forward to the treatment of iron deficiency anemia. Oral iron, particularly those with a high bioavailability, remain as the first line treatment and is widely prescribed. However, we must consider its limitations such as the gastrointestinal issues which lead to a poor compliance. Considering these challenges, parenteral iron such as IV FCM has emerged as a reliable alternative for managing moderate to severe iron deficiency anemia. Patients with a hemoglobin response less than 1 gram per deciliter at week 2 of an oral iron therapy should be considered from transition to intravenous iron supplementation. Parenteral iron delivers iron directly into the bloodstream, bypassing the gastrointestinal tract, and this eliminates the absorption issues often which are seen with the oral iron, especially in the cases of gastrointestinal disorders. Secondly, it allows for a more consistent improvement in the hemoglobin levels, which is critical during pregnancy to ensure maternal and the fetal well-being. Parenteral iron not only increases the hemoglobin but also effectively restores the depleted iron stores in the body. Compared to the oral iron, the parenteral iron has fewer gastrointestinal side effects and making it a better tolerated option for many patients. Lastly, this method is especially valuable for the patients with moderate and severe anemia, where a rapid response is necessary to prevent all the complications. However, as mentioned earlier, IV FCM should be considered even in mild anemia and during early months of pregnancy, considering the hematological picture of the patient. This slide explains when we should consider intravenous iron. Although parenteral iron is prescribed in moderate severe anemia during pregnancy, specifically after the first trimester, we should intervene at the early stages. By the time a woman reaches the second or the third trimester, moderate or even mild anemia can have significant implications for both the mother and the baby. Therefore, among pregnant women, IV iron becomes an important tool in rapidly replenishing iron stores and preventing complications like preterm birth or low birth weight. IV FCM can be considered as a line of treatment even beyond 34 weeks of pregnancy, provided the other clinical and hematological parameters are normal. However, IV iron is also contraindicated in some of the cases which are listed on the slide here. When we talk about parenteral iron, it's important to understand that not all formulations are just the same. Each has its own strengths and limitations as listed in the slide, and they all impact how and when we use them. Iron dextran, while effective, carries a risk of anaphylaxis. Iron sucrose necessitates multiple doses and lengthy administration. Iron isomaltoside, despite its advantages, lacks sufficient research for widespread use, particularly in the pregnancy. Ferric carboxymaltose is a favored option due to single-dose administration, low hypersensitivity risk, and practically in obstetric settings. The key considerations when selecting parenteral iron should be safety, the efficacy, the dosage, and practicality. FCM strikes a balance between these factors, making it a preferred choice for managing iron deficiency anemia and specifically in pregnancy. Some of the advantages of the IV FCM are listed in the slide, such as the ability to be administered in much higher doses in just a single infusion and lower incidence of anaphylaxis, as seen in the illustration. Ferric carboxymaltose is a macromolecular ferric hydroxide carbohydrate complex, and the ferric hydroxide core is stabilized by a carbohydrate shell. In the bloodstream, the iron from the iron carbohydrate complex is released slowly and is either taken by ferritin or the serum transferrin. This iron transferrin complex binds to the receptors on the erythroblast situated in the bone marrow, providing essential iron for hemoglobin synthesis. Thus, FCM is rapidly cleared from plasma and largely distributed to the bone marrow. And now I hand over to Dr. Jayashree Patnaik for the dose and the mode of administration.
Regarding dose of FCM iron, Ganjoni's formula is the widely accepted and used formula to calculate the doses of IV FCM. Here the 500 milligram accounts for the body's stored iron needs. The target hemoglobin is typically is based on the clinical goals, usually around 11 gram per deciliter for the pregnant woman. This formula allows us to personalize the doses based on the patient's specific needs, including adequate correction of the anemia while avoiding the other doses. Then this slide provides the details on the doses of the preparation of IV infusion. FCM is available in 2 vial sizes. The table details is required volume of FCM based on the iron dose, the maximum amount of sterile normal saline for dilution, and the administration time. While it is crucial to follow these guidelines, always cross-check the packaging label for the manufacturer's recommendation before the infusion. Adhering to these steps helps ensure that FCM is administered safely and effectively. Administering IV Ferric Carboxymaltose or FCM requires adherence to strict guidelines to ensure the patient's safety. These are some of the monitoring and precautions. Dosage units needs to be followed. Do not administer more than 1 gram or 1000 milligram of FCM per week, and the total dose during the single pregnancy should not exceed 1500 milligram, and always dilute in sterile 0.9% sodium chloride solution or normal saline. Although IV FCM is safe, in the majority of cases, ensure availability of the life-saving equipments for the handling severe adverse reaction. Use only sterile and disposable intravenous sets, IV cannula and syringes, and regularly check up the patency of the IV cannula to prevent extravasation of the injection. Do not store the IV FCM or the leftover portion. Discard any unused portion immediately after the withdrawing of the required dose. Avoid giving the test dose as there is no separate vial available for the test dose, and if some portion is unused as last dose, the remaining portion will need to be discarded. These precautions ensure safe and effectiveness of the administration of FCM, minimizing the risk to the patient. Lastly, coming to discuss the critical aspect of the follow-up care after administering intravenous iron therapy. First, the hemoglobin level of the pregnant woman should be reached 4 weeks after the IV iron infusion, and after 3 months to reassess the needs for the further investigation into another undergoing if there is any undergoing causes of anemia. Could there be ongoing blood losses? Could there be a coexisting nutritional deficiency like folate or B12, or perhaps the underlying chronic conditions affecting the iron metabolism? There are critical considerations. To summarize the monitor, reassess and make informed treatment decisions, because follow-up is not just about the checking of the number, but about the ensuring clinical improvement of the patient.